Hello and welcome to the Skinopathy podcast featuring Dr. Jerry Tan, a renowned dermatologist and the president of the Acne and Rosacea Society of Canada. And my name is Richard Pietro, and I'll be your host as we go beyond the medicine and take you behind the scenes to show you how healthcare works and tell you the stories you don't always hear about. As usual, with me is Dr. Jerry Tan. Hello, Dr. Tan.
Hi, Richard. It's a pleasure to be here. Nice to see you again.
Absolutely. And today we have our very first special guest, don't we?
I think it's going to be fabulous. I'm looking so forward to speaking with our guest.
Absolutely. And she is Dr. Shinjita Das. Let me do this. And she is a board-certified dermatologist and the assistant professor in dermatology at the Harvard Medical School. She is also the Massachusetts General Hospital Dermatology Technology Director, and we're both very happy that she's joining us today. So hello, Dr. Das.
Hi, so great to be with you guys this afternoon.
So what I've asked Dr. Tan and Dr. Das to do is to talk shop about the differences in how dermatology is practiced between Canada and the United States, everything from billing to demographics. But at the same time, we're going to get them to talk shop a little about dermatology in general. Now, before we start, and for everyone listening, don't forget to visit getskinhelp.com and have that suspicious lesion or that skin condition checked out by a doctor online. And remember that if you live in Ontario, there are new Ontario laws where you will need a doctor's referral to book an appointment. We are going to put all the links in the description of the episode. So now that we have that out of the way, Dr. Tan and Dr. Das, let's get the ball rolling. And before we get into those differences that I mentioned, I'd like to start with something a bit more juicy. And we're going to start with you, Dr. Das. Mm-hmm. What is your biggest gripe that you have about practicing medicine?
Wow. So, there's several things that really get me, but I think the way that information is collected and conveyed in the electronic medical system, the records, is one of my greatest gripes. And I have to say, when I first came into medicine, it was with the intention of being able to focus entirely on my patients during specific encounters. And with the rollout of electronic medical records, I find myself tethered to the EMR, both before, during, and after clinic. And I find that can be quite draining, especially in its current iteration. So the way that I describe the current EMR system is that it's garbage in, garbage out, meaning that a lot of what the information that we put into the system is free-form text. And so it can be much harder to extract the information and actually develop actionable insights from the EMR. And that can be really hard, for example, if I'm engaging with patients through a patient portal communication, and it's like sending emails. But then when the patient comes in to see me in the office, I'm like, maybe 2 months ago, they sent me a gateway message and I've forgotten about it because I've seen hundreds of patients since then. But if there was a better way for us to synthesize information in an EMR, I think it could really empower physicians to be able to practice at the top of their license.
Dr. Tan, I'm assuming I'm fresh into this space, but I've yet to hear a physician speak glowingly about any kind of EMR. And for those of you who are not familiar, essentially what Dr. Das is talking about is like an enterprise system for doctors. It's a big, giant digital filing cabinet that helps keep track of patient records and helps with billing. But Dr. Tan, what do you have to say about what Dr. Das had to say?
So I want to make sure that you don't think we're colluding, but electronic medical records, without doubt, amongst physicians is probably the biggest yoke we have to bear because it takes us away from patient care. And quite frankly, until the pandemic, I was a dinosaur resisting that move. Mine were all paper. But once the pandemic struck, I couldn't get to my office to get to my files, to get my secretaries to come in to take the files out and to access all those records. So we had to transition very, very quickly. And there are some virtues to electronic medical records. meaning that we can access this information anywhere as long as you have access to the internet, a secure one, and get patient information, evaluate lab reports so that you're not 200 reports behind when you come back from a conference or a vacation. God forbid, yes, we do take vacations. But it's one of those parts that it's both a benefit and has these evils along with it. And I agree. I think as we improve the way data is collected, and I think one of the ways that we can improve things is how we actually input data instead of sitting in front of a screen typing it out. Is that what you do, Shinjita? Do you go kind of room to room with your laptop, or you have a PC in there?
So we have a PC in every exam room, and it's always this struggle between, do I, come into the room, introduce myself to my patient, and then log in and risk having my back turned to my patient. And especially in dermatology, our appointments are booked as 15-minute appointments. If it takes 2 or 3 minutes to log in, access information, that you've already used up a good chunk of the visit. So what I find myself doing is actually stacking notes. And by that, I mean, I'll see a patient, and if there's already a next patient ready, I'll go see the next patient, but then leave my notes till the end of clinic to write them. So then, I'm trying to remember the visits, but also it extends the clinic time into the evening hours, and certainly kind of makes the days a little bit longer.
Do you have scribes in your exam rooms or nurse assistants?
We have. So I practice in a large academic health center. And so I have colleagues who engage with scribes both in person as well as virtual scribes. I tried that for a while, and I found that given my practice style, being mostly general dermatology, that I could template a lot of my notes on my own and be more accurate. Because oftentimes scribes are individuals who are not physicians, but perhaps they're pre-med students who are just learning the language of medicine, much less the language of dermatology. And so I found myself having to go back and edit and revise the work, which was then adding more work to my workflows. How about in your practice?
Actually, before you do that, I need to share a quick anecdote. I'm a big fan of the TV show Scrubs from like 20 odd years ago. And I remember there was an episode where one of the residents, the lead character, talks about medical interns. And it was like, find me an intern that doesn't triple the amount of work that I have to do, and I'll kiss their feet. And I think that's a little bit what you're sort of describing right now. Sometimes people can get in the way. It slows you down.
Yeah. And it's part of the learning process. But at the same time, when you're trying to be efficient, but at the same time, maximize and optimize for the patient engagement portion of the encounter, which is what really keeps me attached to medicine and excites me. Sometimes it's that burden of all the administrative side of things that can be quite a drag.
Oh, I completely agree. And you know what I really like, Shinjita, because I do have nurses who, quite frankly, are much better at data gathering than I am. And by the way, they're better at counseling than I am. I'm not really quite sure what I do in the office, actually. So, and over the past few years, I've redefined what my role is, which is when I get into the room, my entire task is to completely engage that patient with my entire focus. That is, I don't want to look at a computer. I don't want to be turning away from that patient. If you have your derm light with you or your magnifier with you, you introduce yourself and your equipment because, by the way, I'm going to be examining you with these instruments. They could be very bright. You might want to keep your eyes closed when we do this. And for example, if we're doing a full body assessment, I might say to the patient, next time you come in for one of these, feel free to bring in your bath gown, your bathrobe, and sit in your fuzzy slippers. It's way more comfortable than our luxury paper gowns. And, that way you can be comfortable, you can be warm. And then when we're ready to do it, you'll be just ready to show me whatever you need to evaluate. And I always start from the foot first, because sometimes we just forget the bottom of the feet. And I find if they're sitting down, they can just swing up their feet, take off their fuzzy slippers, and then I can start evaluating, then progressively ascending as I go. And, as I do that, if there are any spots that look a little suspicious, then I might say to the nurse in the room, let's just take a moment for this one at, let's say, this particular anatomical site. This is my description, and she'll write it down. Then I'm always right there in front of that patient, knowing that they've got my full attention. What? How about you, Shinjita? Like when you are actually doing your assessment, do you have to kind of write down paper notes and then come back to your electronic medical records?
Exactly. So in my clinic, and again, I work in an academic center rather than a private practice, and so I don't have the luxury of having a nurse or a medical assistant in the room with me with each patient encounter. So oftentimes the nurse who's in the clinic with me is rooming the next patient. So what I'm hearing is a little bit of a practice difference where you have a medical assistant or nurse who's at the elbow helping you throughout that examination.
And I'm also kind of curious to know, Dr. Das, just personal sort of style. Doctor
Mhm.
Tan likes to start with the feet, and more specifically, the soles of the feet.
Yeah.
Where do you start your full body examination?
So I start with the hands, actually. So I start at the hands, work to the arms, down to the feet, and then I actually have my patients lie down on the exam table. So then I examine their back, and I end with the face. But I really like that idea of starting with the feet because oftentimes it's a location that is a bit non-obvious in terms of areas that might be affected by skin lesions or concerns for skin cancer.
Are there, like, I'm curious for the both of you right now, because obviously, Dr. Das, you are based in Boston. Dr. Tan, you're a Canadian doctor and you're based out in Windsor. And I know you've also practiced in the United States, but I'm curious to know about the different types of patients that come in through your doors. Because obviously, when we think of dermatology, the very famous Jerry, like the Seinfeld episode, Dr. Pimple Popper, and everyone, most people think like it's about acne and things of that nature. But you guys must have a wide range of patients that come in for a wide range of different issues. But I'm curious to know if they're the same based on the markets that you're in. And Dr. Tan, please, if you could give us a basic patient profile, generic patient profile that comes through your doors.
Okay, so I'll just give you the spectrum of what I see. I'm a general dermatologist in a fairly small city in Ontario, a fairly large province in Canada. And because it's general derm, I see anyone who's referred from the public domain. That is, they can be of varying, financial means. They can be of different ages, and certainly with the changing landscape of Canada, of all different ethnicities and races. And so there is no one particular archetype. There are many, many people, and some of them extremely well to do, others not so much. But, my job is to serve them all.
Do you
Uh,
find mostly it's like acne patients that come through your doors? Is it people that have like moles and blemishes and want to remove? Is it eczema or dry skin because it is sort of, drier in the winter, for example? Do you see more of a certain type of skin condition than others?
Oh, absolutely. And I think that given that Windsor and Boston are probably facing the same type of climactic conditions, it will be very, very seasonally driven. And because I'm general, I don't limit my practice to only certain types of conditions because otherwise I wouldn't be able to serve the community properly. So, although my research focus is acne and rosacea, when I do practice, I practice and am ready to see basically all comers.
How about yourself, Dr. Das? Do you see any sort of trends in terms of type of patients you see or the conditions that you need to see?
Yep. So I'm also a general dermatologist. And so for me, that ranges from seeing teenagers through the elderly across various demographics as well. And so I would say I see bread and butter dermatology, which would be predominantly skin checks, so skin cancer screenings, also acne, rosacea, eczema, psoriasis, and even more complex conditions requiring systemic treatments, meaning treatments with pills or injectable medicines. One of the things being at a large healthcare system is that I have colleagues who have chosen to subspecialize. And so oftentimes, as a general dermatologist, I am a filter of sorts. So I'm able to see patients. And if we see that they're not responding to first or second line treatment measures, I have the flexibility to then refer to my colleagues who are then subspecialists who oftentimes are also doing research in that area of expertise. And so, within my healthcare system, most of my patients have private insurance, meaning from their employer, although I have patients who have government insurance, which is either Medicare for the elderly, 65 and plus, or Medicaid, which is for our more indigent populations. And so, as I mentioned, bread and butter dermatology, and similar to Dr. Tan, I see patients from all walks of life. So in a morning session, I might see a patient who is homeless or has housing insecurity, and an hour later see an executive of a multinational company. And so it's really a privilege, being in a large city, that I get to see those demographic differences. And anyone who has skin, I can see. So that counts for most folks.
that doesn't count unless you're a reptile, in which case, they're pretty much self-serving. But let's get to some of the real big differences. Let's talk about billing. And let's just go with something simple that people can sort of work their way through. Dr. Das, let's say somebody comes in with a suspicion of a melanoma, and you got to run some tests, and it turns out to be melanoma, and you need to do the excision itself. Let's say it's on a person's face. How much do you get to bill for that excision to the private insurer? We don't need to know hard numbers, but can you give us a ballpark figure? Because I know I was shocked when I saw the differences between the U.S. and Canada on that front.
Yeah. So most of my patients have private insurance, which means that usually their employer is the entity that's subsidizing that health insurance. And so every health system, so in the U.S., we're fee for service, meaning that for whatever service is provided, there's a fee that's generated. And that's generally through what we call CPT codes, or current procedural terminology codes. And so if a patient were coming in to get a skin biopsy, the actual cost of that can vary dramatically across practice settings. So if they were seeing a private practice dermatologist in a rural setting versus a larger health system in a big metropolitan city, that pricing can be several hundreds of dollars difference. So for me, I basically put in the CPT codes, and my employer, since I'm an employed dermatologist, deals with the billing. But the range can be, it can be a few $100s to as high as $800 or $900 for a skin biopsy.
Just for
and
a
those
straight skin
fees,
biopsy. Yeah.
Exactly. So that can be for the service of doing the biopsy, but then there can be additional fees for the pathologist to do the reading of the slides and to evaluate them under the microscope. And so one thing we have to bear in mind is there could be an amount that's charged. So there could be a bill that goes out, but the insurance companies, as well as the practice, will oftentimes negotiate and come to a final actual paid price. So whatever is billed may not actually be the price that's recouped by the practice.
So, and I apologize, I'm going to ask for our audience a more direct type of question. Let's just stick with biopsies for now, then, as opposed to, say, excisions. Let's say I come in, I have suspicious something, you need to get a biopsy, and you're in Boston right now. So it's a very big metropolitan region. How much do you think, ballpark, you would be able to bill, or your employer would be able to bill for that biopsy?
So
you said $800?
It's impossible to know. And again, getting to the point that because every insurance company negotiates a different rate with the practice. So if there's an insurance company that is contracted with a specific practice, they may negotiate down a lower fee. So whether it's 100, 200, 800,000, there's no set fee, because there can be a cost that's charged, but the actual that's paid out can be dramatically lower.
Gotcha.
Especially for the insured patients, there's no fixed sort of fee for that. And even if it's an out-of-pocket expense, so if a patient comes in and says, I don't have insurance, each institution might have their own charge master, as it's called, but then even that fee is negotiable. So that's where it gets really tricky in terms of how money flows through the healthcare system, is because the numbers can be negotiated.
How about yourself, Dr. Tan? Give us a bit of a profile of building for biopsies and things of that nature with the Ontario Ministry of Health.
So Shinjita, I trained for a year at the University of Michigan, and it was a revelation to me because of all the different payers that the backroom staff had to deal with. So that just blew me away. Then when I came back to start practicing, there was one payer. That was the government, or technically the Ministry of Health. So basically, it does streamline things, but then it is also somewhat monopolistic. In fact, it is completely monopolistic because there is no negotiation. You get what you get because that's what they tell you, that's what you get. And you cannot negotiate anything with the patient, by the way, because that would be outside the policy and regulations. So it is what it is. And whether you are 1 year out of practice or the world expert on whatever it is in dermatology, your consultation fee will be the same. So for us, the consultation rate is just over $70+, and follow-up is about half of that. Excision for a malignant lesion, which includes the biopsy, by the way, is $90. And that is what the fee is set at. I think it's a little bit less if it's off the face. And of course, you do get more if you take off more than one at a time. But that's basically it. So I must tell you that it was a revelation to me when I came back to practice in Canada. And after having seen some of the codes and the numbers beside the codes from Michigan, I thought, I think we're missing a few zeros here. What happened? But that is the nature of the difference and I'm glad you pointed out the difference in billing versus reimbursement. You can bill what you think you can get, but in the US, you'll be reimbursed on what has been negotiated.
Right.
So
exactly. Yeah, and it varies exactly.
Yeah, because actually I remember John Oliver had a big bit about that in terms of how healthcare debts are oftentimes traded like horses, at least in the United States, it seems like. But we don't need to get into the political side of things. But Dr. Doss, you just heard Dr. Tan talking a little bit about, like, he charges $75 Canadian for an initial consult, half of that for a follow-up. Would you be happy with that if that was what you were getting paid? Because obviously you're not an entrepreneur, you are a salaried doctor, but what is your thoughts in hearing that?
Right, Richard, you said she was with the Faculty of Business.
Yeah. The Harvard Business School.
Maybe you're willing me to go to business school at some point. But
I think we all want to do that, Shinjita.
Right.
Sorry.
So to answer that question, I hear $70, and that number in itself, I would need more information, because of course it would be helpful to know what are the overhead, because Dr. Tan is running a medical practice. So what's the sort of overhead, how much time spent with each individual, and then from there being able to calculate out like the total net revenue. So 70 by itself is a little bit of a difficult number to understand without understanding the practice costs.
You guys are so safe right now.
Well, because for me, as an employed physician, the salary that I earn takes into account my employer's overhead, and then the other expenses related to that. So that type of information is what I'd have to certainly take into account. And
that's actually go ahead, Dr. Tan. Sorry.
You know what's wonderful about that is how diplomatic that response was. So most of us run probably about anywhere from 30 to 40% expenses in our
Hmm.
practice. And unfortunately, through the pandemic, because of institution of EMR, um, plus the fact that with EMR, you just can't see as many patients, your revenues
Mhm.
fall, your expenses go up, and you have this increasing proportion that's going to overhead. So it's not an enviable place to be when that happens, because I think the nice part with what you have with your situation, Shinjita, is that you have an institution that has the wherewithal to put a PC in every room. We have laptops that we uh, you know bring to from place to place because that's more efficient for us. And it's a very different system, partially, but also because of the way, I'm for fee for service, you are salaried. You probably have some protected time to do the additional research and other um, activities that you're involved with, which is great. I have protected time to go to yoga, and that's about it. So I wanted to ask you about your other interests in dermatology, Shinjita, because I think that's remarkable that you have this additional scope. So perhaps you can let us know what that's all about.
Yes, and so I've had the great opportunity to practice as a dermatologist and really start to identify some of the pain points. One of which we kicked off this episode with. But as the department's technology director, I get to wear multiple complementary hats. So, in addition to seeing patients in person, I also do virtual visits, both in a Zoom type format like we're doing here, but also asynchronous teledermatology, which allows me to provide consultative services to other specialties across our integrated healthcare center. We
So
call these e-consults.
e-consults, but you said the word asynchronous. I recently learned about synchronous and asynchronous consultations. Would you take a few moments and explain the differences for people who are not as lucky as me?
So synchronous telemedicine is the way, like something like we're doing right now, where it's in sync in real time, having a video type visit. On the other hand, asynchronous telemedicine allows us to separate that encounter not only in space, but also in time. So in dermatology, what that might look like is a primary care doctor is seeing their patient in their office and takes some photographs of a skin condition and then sends a message through the EMR to me that I can then reply to in a day, within a day or two. So then it basically separates out in space and time.
It'd be kind of like emailing back and forth a little bit.
Exactly. So it's like an email in a more structured format within the EMR. And so that's been a program that I've been able to build out across our system here, but also have been starting at the hospital level to expand out where we provide dermatology e-consults or asynchronous telemedicine to neighboring healthcare systems who don't have as many dermatologists locally. So that's been a really exciting opportunity to really take from the tailwinds of the pandemic. And I think one of the one of the silver linings of the pandemic, I hope, will be that we start to think of more creative technology based ways to provide care and to connect people ultimately. So I've been getting to do that. And I also get to work with medical students and residents and provide them exposure to telemedicine and digital health. And so that's within the institution. And of course, as had also had an opportunity to advise for startups, and that's been a really fun way to start to really look far into the future, whether that's 2, 5, 10, 20 years into the future of what healthcare might begin to look like, and to play an active role in it.
So can I ask you, since you had kind of led us that way, and without giving away the prize, what tantalizing bits of um, information can you share with us where you can see, wow, this is a hugely innovative step?
Oh, you're back, Dr. Das. Oh,
I'm back. Yeah, it cut out for a little bit. Sorry.
so can you repeat your, actually, Dr. Tan, before you ask that question, I want to stay on asynchronous medicine for a moment, and then we'll go back to your question, because I want to ask you, Dr. Tan, from my understanding, asynchronous consultation, which is what Dr. Das is pushing, like the ability to help somebody out of time, sort of as emailing back and forth and reaching out to patients that might be 2, 3, 4 hours away from her. That's not allowed in Ontario. Am I wrong in thinking this?
Well, the Ministry of Health actually has Telederm Ontario that uses phase forward technology, which is exactly that, where the inputting clinic has demographics, history in kind of very brief summation format, and then photographs where you can kind of zoom in or pan around to see what else the lesion and the rash looks like. So that is available. It's a little bit slow and clunky, but it's actually in Ontario.
But it is only within the purview of the Ministry of Health. Like if you, Dr. Tan, wanted to do some asynchronous medicine, for the lack of a better term, on your own terms, you would not be able to at least bill for it. You'd be able to do it, of course, but you wouldn't be able to bill for it with the ministry. Is that correct?
Now, that's an interesting question because we have it depends on what's happening with the video and the virtual codes. So some of the virtual codes during the pandemic were fairly, they were very flexible to allow this type of virtual care. But even at that time, it had to be synchronous, live. That is, you had to be in sync, and the async wasn't, as I understand it, it really wasn't allowed. But what would happen is patients would send you photographs. Shinjita, I have a story for you. One of the first times I received a photo that I thought, oh my God, what's happening? Is the aha moment. I had just gotten off my exercise bike. We were still in hard lockdown, and this photograph of a tumor on a man's nether regions showed up. And I'm thinking, this isn't good, which means that I have to do something on an area that, I rarely ever do surgery on. And there was no surgeon I could muster that would do anything. But that was one of my first asynchronous photographs from a patient.
Wow.
That is, can you help me with this? And
And
it was indeed a squamous cell carcinoma on the penis.
wow. And what you're highlighting, and I'm such a strong proponent of asynchronous, is that literally a snapshot allowed you to make a tentative diagnosis and to fast track that patient's care. So for us, one of the benefits of the e-consult program is to be able to triage patients. So on average, wait times can be 4 to 6 weeks, although during the pandemic and as we're emerging from the pandemic, our wait times have become 4 to 6 months. And so through e-consults, we have an opportunity for a clinician to lay eyes on a photograph and to be able to empower primary care with either first or second line treatment options, or in the cases where it's a severe rash or something suspicious for skin cancer, we can fast track the patient into the dermatology clinic through a specialized mechanism so that we can take a potentially 4-month wait time and condense it down into a week or less, which is really powerful, especially when we have such a backlog of patients in terms of the wait times.
So, Dr. Tan, earlier, there was a bit of a technical glitch, and you had asked Dr. Das a little bit, because she is at the forefront of technology, if there was some really neat stuff coming out. Do you want to repeat your question for Dr. Das, and we can get right on it? So I don't want to ignore you, because we got to start thinking about wrapping up the episode here.
Yeah, Shinjita, what I was wondering about was, with your expertise and your experience with innovation in this tech derm space, what are you seeing that you can share with us in tantalizing tidbit form about what excites you?
And feel free to talk
So
about skinopathy as much as you'd like.
Well, one thing that really excites me is the amount of work that's going into using skin photography and skin images in order to diagnose skin conditions and specifically skin cancers. And so there's a whole slew of companies who are working on this, Skinopathy being one of them as well. And so I'm really excited about that because with AI-based image recognition, we can really take this concept of e-consults and put it on steroids, where you can use a computer-based system to really help to triage a panel of patients and be able to get patients the care they need when they need it. And then it also allows providers to be able to work at the top of their license. So if a lesion is obviously benign, and Jerry, you and I have both had cases where a patient comes in with a changing pigmented lesion. We take one look at it and we're like, okay, this is definitely an SK. We put our derm light to it, and yes, it's a benign SK or seborrheic keratosis. And so if there's ways to be able to give patients that reassurance without the hassle and tension and worry of having to wait for a dermatology appointment, I think that is very powerful. Another area that I'm, very excited about, and certainly has been in the public space, I think over the last few weeks and months, is Chat GPT. So it's it's an AI-based natural language processing algorithm that is basically available to the public to use as a chatbot. And I was fiddling around with it yesterday because I was thinking, how can we use this in some way in medicine? And it's so powerful. Jerry, getting back to what you said about how you felt that your nurses and your team were better at counseling or certain aspects of patient education, you could think of like ChatGPT and that sort of AI-based technology as being really powerful for being an extension of clinicians for patient education. Or I would love to see this. So whoever's watching this, if you're, thinking of a startup idea, but using ChatGPT to actually be able to have an API into the EMR and be able to take that EMR data and be able to synthesize that into actionable data for clinicians, for patients, and to help find trends that might not be obvious to someone who's just having to manually skim through the medical record. So those are the two things lately that I'm very excited about, is just how to automate and help synthesize information so that we can really focus medicine on what it's supposed to be about, which is about the people to people connection, and have the technology working in the background rather than being an encumbrance in the foreground.
I want to say real quick before Dr. Tan, you come in on this one, because I'm sure you got a million sort of comments. To anyone listening, while Dr. Das made a fantastic request and recommendation, follow the privacy laws. There's a lot that when it comes to personal health data or personal health information, depending on your jurisdiction, that comes into play here. But that's one of the reasons, in fact, that the conflict with protecting a person's privacy, because health is sacred for a lot of people, and then bringing in technology, is how do you marry both things together while promoting innovation, but at the same time protecting that individual from, mistakes happen, and the last thing you want is to find out that there's like a million people that have HIV/AIDS, and ChatGPT has got that information and using it for a number of different reasons. But real quick, Dr. Tanya, please, if you want to respond.
And are there any other features that you find have been tantalizing? And part of, I'm just going to throw this out because this is not a technology we have in Canada, but the use of gene rearrangement technology in terms of gene chips and testing of individual lesions, and then those samples are sent off to a central processing lab to evaluate the probability of those gene abnormalities being related to malignancy. I think that's actually really interesting to see, and actually now come to commercial fruition. Is there anything like that that you're sensing is coming as well?
So I focus mainly on the digital health space, and so part of the gene arrangement. Sorry, it was cutting out. So I think that it's a really exciting space, especially for a lot of our what we call genodermatoses, which are genetic conditions that. One of those that come to mind is epidermolysis bullosa, which is a condition where there's a genetic defect that causes patients to develop blistering sores all over their body that are very slow to heal. And so it's really exciting to see where that space will go, especially when we think in terms of therapeutics for our patients. Like if we can, one of my other beefs with with dermatology is that a lot of our treatments are more as management rather than cures for disease. So if the gene rearrangement studies and research can help us actually cure dermatologic diseases, I think that would be such a win for the specialty and for healthcare broadly.
Dr. Tan, I want to ask you about this because we're talking about data, we're talking about innovation. Dr. Colin Hong, who's a co-founder of Skinopathy and Get Skin Help, once told me the following thing, and I was shocked. And this goes back to EMRs real fast, that Health Canada, and I'm assuming the FDA does the same thing, will issue recalls or warnings of certain drugs. Now, Dr. Hong told me over the course of his career, he's had over 100,000 patients. When that recall or warning comes in on a drug, he can do nothing with it with anybody in the past unless he remembers, because he cannot go inside his EMR and pull up like, who are my patients that are on drug X that I just got a warning about or a recall about or whatever. There's no way they'll ever find out. And that's the static nature of data inside of EMRs that we're talking about. Dr. Tan, you were mentioning a little bit like you'd love to have a little bit more, a little bit more fun with your practice and be able to do more things with your data. Like, I'd love for you to, what are your thoughts on this?
Yeah, I think that's actually quite remarkable because it extends totally into the liability space. Like, if we're not allowed to contact the patient and we can't access it to find that type of information, and then reach out and say, by the way, here's a recall, are we liable or not liable? Because we're not allowed. So I think it brings up a whole other aspect of care that is, and maybe it goes to the pharmacy level, and the pharmacists then have the responsibility of saying all the people on these drugs maybe those would be foci for you to be informing to ensure that you let them know about this warning. I wanted to just touch base with Shinjita because, she and I both talked about the full body examination. And it seems to me that this would be a fabulous place to digitize and automate. So I can see an Autobot Shinjita or an Autobot Jerry. Shinjita better because she's so much better looking, but you can make it like really neutral. And you go into the scanning room, and basically you have this array of cameras that just photographs everything, right? And including the bottom of your feet, and you open your mouth, the inside of your mouth, and then those images are scanned in AI. And it's only the ones that are problematic that then go on to further human assessment, let's say. And dare I say, it's almost like going through airport security. You put your arms up, it scans you, and then ciao, I'll see you next year unless you give me a call back and say there's a spot you want to look at. So I think that's the next startup, Shinjita.
I think that would be so powerful. And, certainly, Richard, your input would be helpful for this. I think something like that where you can really screen patients and help to fast track, because so many of the patients whom I see are the worried well, meaning that no history of skin cancer, but maybe there's a family history and they have a little bit higher risk, or maybe a sun exposure history. And if there's an opportunity for us to screen and release from a clinical setting, that would be really powerful, again, for helping ease the bottleneck in healthcare. And then technologies that can track. And what's beautiful about this is, depending on if the images are being stored over a period of time, that change can be potentially detected if there's a lesion of concern or whatnot.
Well, at the risk of sounding self-serving, Get Skin Help is on the verge of doing that, and some of the technology coming out of Skinopathy will be helping. Not so much the sort of the full body sort of suit that people can wear, but soon enough, I think that technology is on the cusp. Although at the same time, that's one of the reasons why we're working with the Responsible AI Institute, because there are plenty of elements of AI and advanced technologies that need to take into consideration, biases towards color, policies around, how do you deal with false negatives and things of that nature. And all to say that this is a conversation I think that's going to keep going. We need to wrap up. Unfortunately, I'm sure we'd love to keep the conversation again going right now because it's been so sort of exciting and insightful. But I want to give you both sort of a few moments each to sort of wrap up any thoughts, anything that you wanted to say that you just didn't get a chance to say. And again, Dr. Das, you're our guest today, so please start.
Yeah, no, thank you so much for having me. And what's been really fun is to talk about some of those similarities in terms, especially patient demographics across Canadian versus U.S. Dermatology, but also some of the differences in terms of how reimbursement works. Again, I consider myself a technologist. I'm very excited about what the future holds in terms of fast tracking and streamlining the way that healthcare is delivered. But my real hope for the future is that by using these technologies, we really enhance the people-to-people interaction. And I see that, over time, that interpersonal connection being lost because of all the technology that's in between the patient and the doctor. So Skinopathy and all the other companies who are out there working, help us bring humanity back into medicine.
And Dr. Tan, any sort of parting thoughts?
Well, it's been a pleasure speaking with you, Shinjita. It's always interesting to discuss differences, but also similarities. And just to echo what you said, often when I drive to work, it's not the difficult case that I'm thinking of. It's kind of, how do I make a patient who's worried smile?
Mm.
How do I finish by providing them a service either so well or to assuage their concern that they leave with a sense of satisfaction and positivity. So, and I think you're absolutely right. The more we spend behind our screens, the more difficult there is to have that human connection. Totally agree.
And that was the one thing that I really sort of took back from the conversation with you both, which reinforced a lot of what I've come to learn in the last 2 years, which is doctors want a doctor. Doctors don't want to get bogged down with the bureaucracy and dealing with billing, things like that. They're primarily preoccupied with the patient. Like you were saying, Dr. Das, if I got to log in and turn my back, I've just lost 2 to 3 minutes with that patient. Dr. Tan, you feel very much the same way. And it's fascinating to see those similarities in terms of a doctor. It's almost a calling. It's almost a calling for them. They want to help patients. So let's get as many of the burdens out of their way and help patients. Dr. Tan, it is Skinopathy the Skinopathy podcast featuring Dr. Tan. So it's always nice having you on. Dr. Das, I feel confident you're going to be back as a guest on this podcast.
Oh, I'd be honored to. It has been a blast.
Oh yeah, and I think we're just gonna get better. We're just gonna get better. So as usual, guys, for those of you listening, you can find out more about Dr. Tan by visiting his personal clinic website at healthyimage.ca. He also has this acne decision tool at inform-decisions.org. And if you want to find out more about Dr. Das and her work, go to massgeneral.org and find her there that way. And as usual, please, share the episode, leave us a like, leave a rating, leave us a comment on how to make the show better, or if you have any guests or any stories that you'd like to hear more about. So until next time, go to getskinhelp.com, have that suspicious lesion or skin condition checked out by a specialist, and keep that skin healthy.